Welcome to CME on ReachMD. This activity entitled The ABCs of Connective Tissue Disease Pulmonary Arterial Hypertension, Algorithms, Team-Based Approach, and Combination Therapy is provided by the Academy for Continued Healthcare Learning and supported by an educational grant from Actelion Pharmaceuticals US Incorporated, a Janssen pharmaceutical company of Johnson & Johnson. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements as well as the learning objectives.
Hi, I'm John Ryan. Welcome to our educational session today. We're going to be talking about screening for pulmonary arterial hypertension in patients with connective tissue disease. So I am a director of pulmonary hypertension clinic at the University of Utah. And today we're going to be covering the recommendations for screening and then actually also how you do your screening when looking for pulmonary arterial hypertension. The reason that you screen in the setting of connective tissue disease is because of the increased prevalence of pulmonary arterial hypertension in people with connective tissue disease. I always think about this is that, we quote the prevalence of pulmonary arterial hypertension in the general population about being 1 in about 100,000, something along those lines, rare disease. In people with connective tissue disease, scleroderma, lupus, rheumatoid arthritis, mixed connective tissue disease, among others, the prevalence is much higher. It's about 5%, so it's about 1 in 20. So it's still, if you have connective tissue disease, it's still unlikely or uncommon to develop pulmonary arterial hypertension, but the relative risk is much higher, going from 1 in 100,000 to 1 in 20 clearly is a several-fold increased risk. The other reason that it's important to screen for pulmonary arterial hypertension in connective tissue disease is because the delay in diagnosis results in worse outcomes. So we know that the average length of diagnosis from symptom onset to diagnosis of pulmonary arterial hypertension is about 2 years already. So in people with connective tissue disease, due to some challenges with the diagnostic criteria, which we're going to touch on in a couple of short minutes, ultimately they can end up with the diagnosis being delayed. Unsurprisingly then, more advanced disease, patients with more advanced disease at presentation therefore have worse outcomes. Now, the other issue is that people with connective tissue disease, people with lupus, people with scleroderma, people with mixed connective tissue disease and rheumatoid arthritis who go on to develop pulmonary arterial hypertension, their prognosis is much worse than people who have idiopathic pulmonary arterial hypertension. And we already know that the prognosis for idiopathic pulmonary arterial hypertension is poor. Medicines help, but it remains poor. But the long-term outcomes with connective tissue disease-associated pulmonary arterial hypertension are significantly worse. In our experience as well, people with connective tissue disease-associated pulmonary arterial hypertension don't necessarily respond to treatment as well as, for example, idiopathic or hereditary. So that earlier detection allows an earlier intervention. Try not to fall behind in terms of getting treatment initiated and really being aggressive with the different therapies that we're familiar with in pulmonary arterial hypertension. And in particular, as is increasingly used, some combination therapies. So with that in mind, the 6th World Symposium published in the early 2019, the 6th World Symposium for Pulmonary Arterial Hypertension recommended annual screening for people with scleroderma, also known as systemic sclerosis, recommended doing annual screening. Also, if people have systemic sclerosis or scleroderma and their DLCO is low, less than 80% of predicted, they should also be screened annually for, at the time actually, for pulmonary arterial hypertension. We'll touch more on that in a second. And although scleroderma is the highest risk, there is so much overlap between these diseases, lupus, mixed connective tissue disease, which by definition is mixed connective tissue disease. There's a whole host of different symptoms and signs in there. Primary Sjogren's syndrome, rheumatoid arthritis, idiopathic inflammatory myopathies. All of these things put you at higher risk of pulmonary arterial hypertension, and we would include screening all of these patients once a year with an echocardiogram. Echocardiogram, touch on in a second, is pretty accurate in terms of picking this up early, but it's just a matter of doing it every year. And it's also, you do have to be comfortable with having a lot of normal echoes, because as I said, the prevalence or the risk is 1 in 20. So that means 19 out of 20 people with these connective tissue diseases will not have pulmonary arterial hypertension on their echocardiogram. So there can be a little, not necessarily frustration, but you do need to appreciate that you'll have a lot of negatives for a lot of years before you'll find someone who actually has pulmonary arterial hypertension. But again, going back, because their prognosis is so poor, it's important to screen for it among everyone. Echocardiogram remains, and likely will always be, our most important non-invasive screening tool. It is important, however, for the echocardiogram to be what I refer to as RV-centric, right ventricular centric. Echocardiograms in clinical practice are oftentimes focused on the left ventricle. What's the left ventricular ejection fraction? What's the mitral valve looks like? What's the aortic valve look like? And for good reason. Left heart disease, mitral valve disease, and aortic valve disease are far, far more common than pulmonary arterial hypertension, and more likely to be the cause of patient symptoms. But in our world, in our pulmonary arterial hypertension world, and in our connective tissue disease world, it is just as important, if not more important, to really, what I like to say, to really frisk the right ventricle. So the first thing you do is you do an echocardiogram, and you look at the tricuspid regurgitation volume. The tricuspid valve is located between the right ventricle and the right atrium. Therefore, if there is an increase in what we call afterload, so if pulmonary artery pressures are increased, the blood will not go as quickly in a forward direction, but some of it will actually come back, and that will drive the tricuspid regurgitation. And unsurprisingly, the faster at which it comes back, the higher the pressures downstream. So if you, and these are the cutoffs that we use in echocardiograms, if yours is low, less than 3, then the likelihood of you having pulmonary hypertension is low. If yours is greater than about 3.5, then the likelihood of you having pulmonary arterial hypertension is quite high. And then in that 3 to 3.5 range, you're in an intermediate risk of having pulmonary arterial hypertension. What I do then when you are, really if you're in any of these, low, intermediate, or high risk, is actually tricuspid regurgitation is actually just one thing that you're looking at when you're looking at an echocardiogram screening for pulmonary arterial hypertension. And I actually tell our trainees that the tricuspid regurgitation is the last thing that I look at. The first thing that we look at is the right ventricle. If the right ventricle is bigger than the left ventricle, this is important, because as I've told you, a lot of labs are LV-centric. Well, turn that probe just a little bit, focus on the right ventricle, and if the right ventricle is bigger than the left ventricle, then by definition, and it's an enlarged right ventricle. Trainees will often ask me what size of the right ventricle need to be to define it as enlarged, and you'll see different textbooks in terms of different cutoffs, 4 centimeters, 3.5 centimeters, stuff along these lines. I'm a simple man with simple pleasures, and I think that just having the right ventricle bigger than the left ventricle, that's enough for you to say that this person is high likelihood or increased likelihood of having pulmonary arterial hypertension, especially when they have risk factors such as connective tissue disease. There's also the interventricular septum. Now, this is between the right ventricle and the left ventricle, the interventricular septum. The left ventricle, because it pumps blood to the body, is usually a much higher pressure system than the right ventricle. It pumps blood to the lungs. All there is in the lungs is air. Therefore, the pressure on the right side needs to be low, or doesn't need to be high. If the interventricular septum is flattened, that means that the right ventricular pressures are now getting close to the left ventricular pressures. And in that setting, if the right ventricular pressures are getting close to the left ventricular pressures, the septum will start flattening, so it won't move into the right, which is normally what happens. It won't move into the right. It'll be a flattened interventricular septum. And again, this is indicative of the presence of elevated pulmonary artery pressures on the right side of the heart, and in the right setting with connective tissue diseases is indicative of pulmonary arterial hypertension. So is another echo feature which you should follow. The pulmonary artery itself, then, the key one is really the size of the pulmonary artery. The pulmonary artery should not be greater than 2.5 centimeters. 25 millimeters. The pulmonary artery should not be that big. So if you get an echo report and they say mildly dilated pulmonary artery, that person has pulmonary hypertension, whether it's pulmonary arterial hypertension or pulmonary hypertension due to heart disease or COPD. That needs to be worked up, but they have pulmonary hypertension. So again, if you see someone with connective tissue disease, their pulmonary artery is enlarged, then you need to think about pulmonary arterial hypertension, or at least pulmonary hypertension in general. There are other measurements you can make through the pulmonary artery in terms of velocities. We talked about the tricuspid regurgitation velocity earlier. There are other velocities you can look at flowed through the right ventricular outflow tract, diastolic or pulmonary regurgitation, as well as tricuspid regurgitation, pulmonary regurgitation, to give you an idea. Those measurements are a little harder to do, especially when you end up with, for example, some obesity. They're a little harder to define. So we really rely on the pulmonary artery diameter. But just the same way, if you play Risk, if you play the game Risk, Australia is the key to the whole game. And just the same way that Australia is the key to the whole game in Risk, the right atrium is the key to the whole game in pulmonary arterial hypertension. The right atrium will determine your prognosis and likely your symptoms. And if the right atrium is big, if you have an enlarged right atrium, 18 square centimeters, some people just say 20 just because it's a nice round number. So if your right atrial area gets to 18 to 20 square centimeters, that's an enlarged right atrium. That, in the right setting, exertional dyspnea, connective tissue disease, low DLCO, that's indicative of pulmonary arterial hypertension. You can also look at the inferior vena cava, and if that's dilated, then that is reflective of the fact that the right atrial pressures are high. The IVC feeds into the right atrium. If the IVC is dilated because the IVC has higher pressures, guess what? The right atrium has higher pressures because the right atrium backs up into the IVC. So if your IVC is dilated, that means that your right atrial pressures are increased. And I've already told you that the right atrium is the key to the whole game. So if the right atrium is increased in size or increased in pressure, that's indicative of pulmonary arterial hypertension. And that's actually fairly indicative of prognosis as well. So look at the IVC, look at the right atrium, look at the right ventricle, and look at the pulmonary artery. And if you don't do those things, and if they're all normal, then you're really comfortable. Come back in a year, we'll do it again. If those are abnormal, you need to work it up. There are then additional tests for screening, which really complement the echocardiogram that we just talked about. By far and away, the most useful thing for screening is a history, their history of the connective tissue disease and their history of symptoms. Then the next is the echocardiogram. And these next two then are kind of the next line in terms of determining screening tests. One is, I made a brief mention to earlier. If your DLCO, your diffusion capacity, if that's decreased, but your spirometry is normal, FEV1, FVC, etc. Your FEV1 is normal, your FVC is normal, but you got a wicked low DLCO. That's pulmonary arterial hypertension. Now, admittedly, it can also be pulmonary fibrosis or maybe even some other restrictive lung disease. Can sometimes be heart failure. Either way, it's a bad sign. You have normal spirometry with a low DLCO. That's a bad sign. That needs to be worked up. The most common and most sinister reason is pulmonary arterial hypertension. But regardless of the underlying etiology, it needs to be worked up because it carries a poor prognosis. Then the NT-proBNP, some people, depending on your lab, might use regular old BNP. Other people use N-terminal proBNP. If that is 2 times higher than normal, then that is indicative of high risk of having heart failure or pulmonary arterial hypertension. So that needs to be worked up. And the workup is a referral for a right heart catheterization. So if any of these screening tests are positive, echo, DLCO, N-terminal proBNP, or if your symptoms have just raised your suspicion so high, then you refer on for a right heart catheterization. So in summary, the take-home points here are you've got to screen your people with connective tissue disease every year. Screening with the echo is the best bet. First of all, they could have heart failure. They could have left-sided heart failure. But they can also have pulmonary hypertension, and in particular pulmonary arterial hypertension. And now what I'd like you to do is join me for the next chapter in our connective tissue disease series, which is how to diagnose pulmonary arterial hypertension in patients with connective tissue disease. Thank you for joining me. I hope this was a rewarding discussion. Hi, I'm John Ryan. Today we're going to be talking about diagnosing pulmonary arterial hypertension in patients with connective tissue disease. So I run the pulmonary hypertension program at the University of Utah. And the things we're going to touch on today are the barriers to diagnosing pulmonary arterial hypertension in patients with connective tissue disease. And we're also going to go over the diagnostic algorithm and the clinical nuances in patients with connective tissue disease. I often refer to the diagnostic algorithm as job security. It's so complex that oftentimes when people look at it, they throw up their hands and say, Yara, listen, I'm just going to send it to a pulmonary hypertension center. That, I think, is actually a very reasonable thing to do. And any of us who run PH programs are very welcoming to that, acknowledging the fact that how hard it can be, especially in community practice or in rural parts of this country, how hard it can be to coordinate all the necessary diagnostic workups. As is often quoted and we're often reminded of, there remains a delay to diagnosing pulmonary arterial hypertension. And that delay is just under 2 years. From symptom onset to diagnosis, there's a delay of 2 years in terms of diagnosing pulmonary arterial hypertension. That's too long. The reason for that delay is because the symptoms are deemed to be vague and non-specific. Fatigue. A lot of people go into their primary care providers with fatigue. Exercise intolerance. Guess what? I'm getting short of breath walking up a hill, getting short of breath walking up a flight of stairs. And 90% of people present with dyspnea, shortness of breath. I used to be able to walk 5 miles without a concern. Now I'm getting short of breath at 1 mile, or now I'm getting short of breath inside a house. And I said, so 90% of people presenting with dyspnea and then various combinations of fatigue and exercise intolerance, it does admittedly get challenging. Because if our primary care providers ordered echoes, the main screening tool being echo, if our primary care providers ordered echoes on everybody who was short of breath, they'd be ordering echoes all day long. So trying to figure out who's out of breath because they just haven't been exercising or they've put on weight versus who's out of breath because they've developed pulmonary hypertension is very challenging, especially because, at least as we know in this country, obesity is such a high prevalence, 30, 40, 50% of the population having obesity or being overweight, versus pulmonary arterial hypertension, which is 1 in 100,000 people, is that it's understandable why at least there's a delay to echocardiogram, which then ultimately leads to a delay to diagnosis. It also can be hard to iron out which symptoms are due to progression of the connective tissue disease versus which symptoms are due to new onset pulmonary arterial hypertension. So you have scleroderma, you have lupus, you have mixed connective tissue disease or some sort of inflammatory myopathy. You're not feeling that good anyway. So it can be hard to figure out, has your clinical decline, has it been because you're not feeling good and your disease has gotten worse? Or is your clinical decline because you developed new disease? Now you have pulmonary arterial hypertension as well as having scleroderma. And that can be challenging. The other part of this that's challenging is within connective tissue diseases, the risk of developing pulmonary arterial hypertension is about 5%, 1 in 20. The risk for everyone else, those of us who do not have connective tissue disease, is about 1 in 100,000. But there are also a lot of other diseases that they're at risk for when you have a connective tissue disease. You're also at risk for interstitial lung disease. You're at risk for left-sided heart disease, regular old true blue heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, systolic or diastolic heart failure. There are also then 2 uncommon diseases, pulmonary veno-occlusive disease, an uncommon disease where the pulmonary veins actually develop changes similar to PAH, but on the venous side. and then a condition referred to as chronic thromboembolic pulmonary hypertension, which is quite a mouthful, abbreviated to CTEPH. And this is group 4 pulmonary hypertension, accounts for about 1% of all forms of pulmonary hypertension, but is distinguished by the fact that it's curable with open heart surgery, or more specifically open lung surgery, with a pulmonary endarterectomy. It's particularly common in patients with lupus. And guess what? All of these diseases, pulmonary arterial hypertension, interstitial lung disease, left-sided heart disease, pulmonary vein occlusive disease, and CTEPH, all of them present with shortness of breath, and all of them have increased pulmonary artery pressures on echocardiogram. So it really does rely on doing other workups to determine which is the underlying etiology. Now, the diagnostic algorithm, my goodness, as I've said, it is complex. It is complex and intimidating until you take a step back and just think, what are you trying to do here? You are trying to look at why someone is short of breath. Let's take pulmonary hypertension out of the picture altogether. You have someone who comes in with you with shortness of breath. What are you going to do? I would propose you should do an echo. Do an echocardiogram. I know, as I said before, a lot of people are short of breath because of obesity or other reasons, but try and do an echocardiogram. If the echocardiogram is normal or gives you a low likelihood of having pulmonary hypertension, then you're done from the pulmonary hypertension standpoint. You still need to do a workup for the shortness of breath. It could still be interstitial lung disease, for example. So you still need to do PFTs. But the echocardiogram can give you an indication of how likely they are to have pulmonary hypertension. Before you do the echo, though, I want to take one more step back and actually say that the backbone of your diagnosis of pulmonary hypertension is actually your history and exam. The regular old H&P, as you call it in this country, history and physical exam. So really emphasize those. Look for symptoms of PH, shortness of breath, fatigue, exercise intolerance, maybe even some chest pain, some syncope. Look for signs of pulmonary hypertension, increased pressures in the right side of the heart, right ventricular heave when you put your hand on the chest, peripheral edema. And then you can do some laboratory testing as well, N-terminal proBNP, for example. But again, if someone's coming in with shortness of breath, these are the things you should be looking for anyway. These are the questions you should be asking anyway. And these are the tests you should be doing anyway. So you get an echo and it's higher intermediate probability of pulmonary hypertension. What's next? You can just refer to a pulmonary hypertension center, as I said. We'll welcome them with open arms. But you can also do a VQ scan. As we said, CTEPH is a curable form of pulmonary hypertension. So it is worthwhile just seeing is, can I do a VQ scan? Is that enough to determine the causes of their shortness of breath? And if it is, if the VQ scan is abnormal, guess what? Now you're referring to a pulmonary hypertension center anyway. So if you want, you can refer for the VQ scan, or you can refer to the PH team and then have them do the VQ scan. Now, by far and away, so I often say 60% of pulmonary hypertension is due to left-sided heart disease. So, and then about 30% is due to chronic hypoxic lung disease. Things like pulmonary fibrosis, sleep apnea, COPD, obesity, hypoventilation syndrome. It's that final 10% that's pulmonary arterial hypertension or pulmonary vascular disease, because there's a small component of CTEPH. But 90% likelihood, if you have someone with pulmonary hypertension, there's 90% likelihood it's due to left-sided heart disease, HFpEF, HFrEF, valvular heart disease, or due to chronic hypoxic lung disease. So that's the workup that you do. You make sure there's no left-sided heart disease. You make sure there's no lung disease. How do you do the latter? You do pulmonary function tests. Do pulmonary function tests. Make sure your FEV1 and FVC are normal. If they're not normal, then you're looking at restrictive lung disease or obstructive lung disease. But if you've done the workup for pulmonary hypertension, or as I like to say, if you've done the workup for dyspnea, then the key, and you have found no clinically significant left-sided heart disease or chronic hypoxic lung disease, then you're referring to a pulmonary hypertension center or expert center in order to coordinate treatment and continue the workup. Now, the management of the pulmonary hypertension center is not that much different. It's really the same. It's just we have bigger infrastructure and we have dedicated teams towards this. Those who work in primary care have teams, but they're dedicated to everything: prostate cancer screening, breast cancer screening, calling up results of lipid levels, psychiatric illnesses. So we in pulmonary hypertension centers, we have teams that are dedicated to the workup of pulmonary hypertension. We've got nurses, advanced practice clinicians, medical assistants, we got the whole gamut. So we are very comfortable doing the workup. And as I said, the workup at the Pulmonary Hypertension Center is not that different from the workup, or not different at all, in fact, from the workup outside the Pulmonary Hypertension Expert Center. You do the VQ scan. The VQ scan is abnormal, you're heading down towards CTEPH, and you're working towards it. If the VQ scan is normal, then you're doing this diagnostic workup, ruling out left-sided heart disease, ruling out lung disease. And then you do a right heart catheterization. And if the right heart, for the diagnosis of pulmonary hypertension, and also for the classification, because in your right heart catheterization, yes, all of these people, if you've adequately screened them out, all of these people will have elevated pulmonary artery pressures. What you're trying to figure out, however, is are their pulmonary artery pressures increased due to pulmonary arterial hypertension, or more commonly, left-sided heart disease? And the way you do that is you do measurement, it's quite a mouthful as well. It's called pulmonary capillary wedge pressure. And you measure a wedge pressure. If the wedge is high, then the disease, the pulmonary and PA pressures are high, then it's due to pulmonary hypertension from left-sided heart disease. If the pulmonary artery pressures are high and the wedge is low, then you're very confident and comfortable attributing the pulmonary hypertension to pulmonary vascular disease, such as pulmonary arterial hypertension. However, and I hope I'm not distracting you from this, but this is why we feel, and those of us in the PH community feel, that you need to do the rest of the workup before the right heart catheterization. If you have a high PA pressure and you have a low wedge, you do not know if that truly is due to pulmonary arterial hypertension, or if it's due to hypoxic lung disease, or if it's due to CTEPH. You don't know. So that's why it's important to do pulmonary function tests before doing the right heart catheterization, as well as do a VQ scan before you do the right heart catheterization, so that when you get those numbers, you can tell, the patient can leave the cath lab knowing that their diagnosis is group 1, 2, 3, 4, or less commonly 5. So that's why you do the workup beforehand. Now, the right heart cath is reviewed, the case is reviewed typically by a multidisciplinary pulmonary hypertension team such as ours, and then you classify it, and then you start treatment. You start the treatment for, if it's group 1, for pulmonary arterial hypertension, sildenafil, macitentan, things along those lines. If you're still not sure where they fall, then you can consider a trial of treatment, or you can monitor and bring them back in about 3 months. Now, if they have group 2 pulmonary hypertension, then you're focusing on diuretics, blood pressure control, trying to improve the heart. If you diagnose them with group 3 pulmonary hypertension, then you're working towards looking at bronchodilators, treatment for pulmonary fibrosis, stuff along those lines. If you've group 4, as we said, then you're heading towards surgery, pulmonary endarterectomy. And if you've group 5, then there's a whole host of other things you're doing. Now, connective tissue disease is hard. And there are a lot of nuances to the treatment and to the diagnosis. As I mentioned, the history, the symptoms and signs may not entirely reflect pulmonary hypertension, and in particular pulmonary arterial hypertension. So you can get a little lost in the weeds there. The lab tests, these connective tissue diseases, especially lupus and scleroderma, they're multi-organ diseases. They're going to have maybe some bone marrow suppression, so they'll be anemic. They're going to have kidney disease, so their creatinine will be up. You don't know if they have anemia because they've got bone marrow suppression from their underlying connective tissue disease, or if they got anemia due to anemia chronic disease from having heart failure or pulmonary hypertension. You don't know if their creatinine has gone up because the scleroderma is now involved in the kidneys, or if because the PA pressures are so high that it's backing up into the right atrium, backing up to the IVC, and fluids are building up into the kidneys, which therefore makes them not work very well, and therefore causes some kidney failure. BNP and end-terminal BNP can still be unreliable. In a third of people admitted with decompensated heart failure, the BNP ends up being normal. Autoantibodies, blood glucose, all these things, the imaging, the echocardiogram, we talked about like this in chapter 1, where we talked about using the echocardiogram as a screening tool, looking at the estimated right ventricular systolic pressures, but arguably more importantly, looking at the right atrium size, right ventricular function, and then the pulmonary artery size. The pulmonary function test, there's nuances there. As I've said, you got normal spirometry, you got a decreased DLCO, that's likely pulmonary arterial hypertension. However, if you have abnormal spirometry, decreased FEV1, decreased FVC, and you have a decrease in DLCO, That could be restrictive lung disease. But guess what? There is no law saying that you can only have one disease. So you can have restrictive lung disease, such as pulmonary fibrosis, and also have pulmonary arterial hypertension. Cardiopulmonary exercise tolerance testing then can be challenging, especially over the last year with COVID, because of all the exhaled and inhaled gases with exercise. 6-minute walk test can be affected by things other than pulmonary arterial hypertension. Granted, our clinical trials have relied heavily on the 6-minute walk test. But if you have connective tissue disease, you've got arthritis, you've got scleroderma, you've got weight loss, guess what? That's going to impact your 6-minute walk distance as well. And then the right heart catheterization, I tried to make it simple for you there by saying that if the wedge is high, it's left-sided heart disease. But then I said if the wedge is low, then you have all these other things it could be. Group 1, Group 3, Group 4, Group 5. So it does require a set of eyes that do this all the time. Even if it's just for the diagnosis, even if it's just day 1 to 30, get them into a pulmonary hypertension center. They give you the diagnosis and then have a discussion with that team to say, do you want to continue to follow them, or can we coordinate care in the primary care setting? So in summary, someone comes in with you, connective tissue disease and shortness of breath, you got to think of the uncommon things, pulmonary arterial hypertension most particularly. The diagnostic algorithm, job security, as I said, listen, any PH program will be delighted to do the workup for you. If you want to keep the workup in-house and then send it on to us to evaluate, happy to do that too. But just make sure that you do a thorough workup. And as I said, although we say the workup is for pulmonary hypertension, really that workup is just for shortness of breath. So that wraps up chapter 2. Hopefully this has been a rewarding experience for you. We'll see you on the other side of chapter 3. We're going to touch on the treatment of connective tissue disease associated pulmonary arterial hypertension. Thank you for your time. Hello, I'm John Ryan, cardiologist and director of pulmonary hypertension at University of Utah. Today we're going to be talking about, we're in chapter 3 of our series for connective tissue disease associated pulmonary arterial hypertension, and we're going to be talking about insights for the treatment of connective tissue disease associated pulmonary arterial hypertension. We will be relying heavily on the CHEST treatment algorithm. I was one of the authors on the CHEST guidelines. We're going to do specific treatment considerations for connective tissue disease associated pulmonary arterial hypertension. A lot of that really depends on some subgroup analyses from clinical trials. And then we're going to look at what's coming down the road. People used to say in Boston, coming down the pike. And then other people say coming down the pipe. So lots of different things coming out there. And we want to look at each of those. Okay. The treatment algorithm for pulmonary arterial hypertension really, through thick and thin, depends on symptoms. If they in functional class, so you really got to be careful, and you really have, as the Americans would say, you really have to put your nickel down as to what is their functional class. Functional class 1, 2, 3, or 4. Functional class 1 is easy. It's people who are not short of breath at all. No symptoms, just came up on a screening echo, something like that. Functional class 4 is also easy. People who are short of breath at rest. Those people need to be started on parenteral prostacyclins. Where we really have a hard time making decisions is people who are functional class 2 and functional class 3. Functional class 2 is described as getting short of breath on moderate exertion. Functional class 3 is described as getting short of breath on mild exertion. What's mild for some might be moderate for someone else, so there is some subjectivity there. One of the things that our colleague, that our team describes is discussion of if you are short of breath outside the house, and if you can get outside the house, then you're functional class 2. If you get short of breath inside the house, for example, walking up a flight of stairs, putting on your clothes, doing, cooking, then you're functional class 3. So that's another way of looking at it. So then, as I said, the treatment really depends on the functional class. So you really have to commit to what is that functional class of the patient. If they're functional class 1, came up in a screening echo, they have connective tissue disease, they got into their annual echo, pulmonary hypertension came up, then actually you can kind of figure out what you want to do. There's no trials to show that functional class 1 should or can be treated. But you can determine when you want to start treatment and determine if there is some sort of functional decline. Now, if they're functional class 2, then you got to talk to the patient about starting treatment. The typical algorithm in 2021 is to start with what's called upfront dual combination therapy, or dual combination therapy, as the Americans would say. So, and this is driven by what's called the AMBITION trial, which will show subsequently. But there was a time when I was a younger man, there was a time when you would start one drug, follow the patient along. If the patient got sicker, you'd start a second drug, and then follow the patient along again. However, we learned that that wasn't actually a great approach because, as you can imagine, when someone got sicker, it was hard to get them back to where they wanted to be. So the upfront dual combination therapy of a phosphodiesterase 5 inhibitor, often tadalafil, with an endothelin receptor antagonist, often ambrisentan, is the recommendation for people who are functional class 2. Now, as I said, the combination therapy is in the trial, in the AMBITION trial, is tadalafil and ambrisentan. But I've seen every which way combination. You can do sildenafil and ambrisentan, tadalafil and macitentan, sildenafil and macitentan. Some people even do riociguat and ambrisentan, or riociguat and macitentan. And then you can maybe even throw bosentan in there. So there really is a different potpourri of upfront dual combination therapies that you can use. But ultimately, the recommendation is to get people on 2 drugs. There are some circumstances, and me and my team were talking about this today with one patient, there are some circumstances where you'll go with 1 drug, maybe as a trial, maybe to see if they can truly tolerate it. But for the most part, functional class 2, starting 2 drugs. Functional class 3, the recommendation is also to start on 2 drugs. And again, this is driven by the AMBITION trial. And when we say 2 drugs, we mean a phosphodiesterase 5 inhibitor and an endothelin receptor antagonist. Start those 2 drugs, continue to follow the patient closely. If there is a clinical decline, or if they presented with functional class 4 symptoms right out the gate, then, as I said, the decision-making becomes a lot easier, because that does require parenteral prostacyclins, intravenous or subcutaneous prostacyclins. The intravenous forms are epoprostenol, the other and treprostinil. The subcutaneous form is just treprostinil. And that really is the recommendations when people are functional class 4. Now, what makes you functional class 4 again? Shorter breath at rest. Actually, also, I think if you have angina, but in particular, if you have syncope, if you're passing out, then you're functional class 4. So they should be started on parenteral prostacyclins. So let's take a step back and think of those 4 again. Functional class 1, no symptoms, maybe follow them, maybe start a single drug, see how things are looking. Functional class 2, you are short of breath when you're outside the house, walking up a hill, doing your grocery shopping, you're getting short of breath. They should be started on combination therapy. Functional class 3, you're short of breath inside the house, dressing yourself, walking to the bathroom, doing cooking, you're short of breath. You're functional class 3, those people should be started on upfront dual combination therapy. Functional class 4, you're short of breath at rest or you're passing out, they need to be started on parenteral prostacyclins. Now, unfortunately, if they have disease that's so advanced, you do, however, need to also consider a lung transplant. That is a curative treatment for pulmonary arterial hypertension. Now, admittedly, you swap out one disease for another. You swap out having pulmonary arterial hypertension for having lung transplant. You still need to be on medicine. But that is something that's worth considering. And for us, at least, anytime we start patients on prostacyclins, we also have them see the lung transplant team. The other thing to bear in mind is that if you started a functional class 2, if you started a functional class 3, and you're on your dual combination therapy, and you start to clinically decline, your trajectory is that you're going to continue to decline even more. And we know the natural history of this disease, that's progressive disease. We don't have any cures available at the moment. We'll touch on some novel investigative treatments towards the end of this chapter, but we don't have any cures. So it's important to bear that in mind, that you're on your dual combination therapy, you progress, then you need to be started on a third agent. That third agent can be something like an oral prostacyclin like selexipag or oral treprostinil, or it can be maybe you change over from sildenafil to risperidone, or you start an inhaled agent or something along those lines, or you bite the bullet and you start intravenous or subcutaneous prostacyclins. But either way, if you have a clinical deterioration and you're on 2 drugs, you need to be on more. You need to make a change, and you likely need to be on more drugs, or at least different drugs. Now, the goal, as I said, of treatment is determined by the functional class, but the ultimate aim of treatment then is to make people feel better and hopefully make people live longer. However, a challenge with connective tissue disease is just that. They have underlying connective tissue disease. This disease is not isolated to the lungs. It's not even isolated to the pulmonary arteries. They have involvement of their lung airways, pulmonary fibrosis. They have involvement of their heart failure. They have involvement of the kidneys. They have involvement of the skin. Their GI tract is disease. So you also have to bear in mind when you're treating these patients that they also have other diseases, other underlying connective tissue diseases, which make the treatment more complicated and the likelihood of having success it decreases. The other issue that's worth bearing in mind is that some people think that it appears rather, that the efficacy of these pulmonary arterial hypertension therapies is actually lower in pulmonary arterial hypertension from connective tissue disease than it is in pulmonary arterial hypertension from idiopathic or hereditary, etc. So they actually have a worse prognosis. They present later, they present with more advanced disease, and they don't respond to the treatment as quickly. So that's why you really got to keep an eye on top of them and be aggressive. From the great classic movie, Bring It On, be aggressive, be aggressive. You got to be aggressive with these patients. One of the questions we commonly ask, and even earlier on today, my team and I were talking about which of these is the best, which of these should be the one that I put patients on. It's really hard to be definitive about that because there are 13 medicines available in the United States for pulmonary arterial hypertension. And when you're deciding which of these treatments to choose in the different subgroups of pulmonary arterial hypertension, connective tissue disease being the one we're focusing on, but there's also HIV, there's also liver disease, there's also methamphetamine-associated pulmonary arterial hypertension. It's important to compare the treatment responses from these medicines. When you look at patients who have connective tissue disease-associated pulmonary arterial hypertension who are being treated, and you compare those who have idiopathic pulmonary arterial hypertension who are being treated, the patients with connective tissue disease do not respond as well. 6-minute walk test improves by about 23 meters, for example, in this large meta-analysis. 6-minute walk distance might improve by about 23 meters in connective tissue disease, whereas it improved by 40 meters in those with idiopathic pulmonary arterial hypertension. So there clearly is a different response. And that may be, as I've mentioned time and again, the fact that there are differences in the underlying, in the other organ systems that are also diseased. The treatment is less effective in reducing clinical worsening. Clinical worsening in clinical trials has different definitions, but it's predominantly hospitalization for pulmonary arterial hypertension, initiation of prostacyclins, say, lung transplant, atrial septostomy, right heart failure, or death. Death obviously being arguably the worst outcome. And when you are treating connective tissue disease associated with pulmonary arterial hypertension, it just doesn't respond as well than people with idiopathic pulmonary arterial hypertension. So that failure to increase the walk as much is echoed by failure to have clinical improvement as much, or at least to stay off from clinical worsening. Now, the AMBITION trial has been studied, and in particular with connective tissue disease associated pulmonary arterial hypertension. And has been shown that combination therapy, as I mentioned before, PDE5 endothelin receptor antagonist, that did decrease the risk of clinical failure, as well as increased 6-minute walk distance, as well as other surrogate markers of outcomes, specifically N-terminal proBNP. And that its finding is echoed significantly in people with connective tissue disease. So that is replicated in people with connective tissue disease. The bulk of the people in that trial who had connective tissue disease did actually have scleroderma. So then the Selexipag trial, which was referred to as the Griffin trial, that did decrease the risk of another composite endpoint, morbidity, mortality, end-terminal proBNP, 6-minute walk distance. So it did reduce that composite endpoint. That was the primary endpoint. And again, in a subgroup analysis, 80% of the people in the subgroup analysis, incidentally, were already on therapies, PDE5s, endothelin receptor antagonists, or both. And in that group, they echoed the results that we saw in the primary endpoint for the large study was echoed or replicated in the connective tissue disease group. So it was consistent across between the two groups. In particular, despite the fact that patients were on some sort of background therapy. So we can safely say that the dual combination therapy that we've talked about works in all populations of pulmonary arterial hypertension, works just as much in connective tissue disease-associated pulmonary arterial hypertension. Selexipag then in the Griffin study worked in all populations of pulmonary arterial hypertension and worked in pulmonary arterial hypertension from connective tissue disease. Riociguat was studied in the patent trial, shown to improve 6-minute walk distance. Subgroup analysis was also published in this group, which showed that there was a sustained improvement in connective tissue disease-associated pulmonary arterial hypertension in people randomized to riociguat. Functional class improved, 6-minute walk distance improved, pulmonary vascular resistance actually went down, which is a good thing, and cardiac index went up, which again is a good thing. Now, admittedly, the improvements were not as pronounced in other groups within the trial, but as we've said, there's oftentimes comorbidities here. And those comorbidities are oftentimes pulmonary fibrosis or interstitial lung disease. And this is where it's become more complicated in the last 6 months, because within the last couple of months, we now, for the first time, have dedicated treatment available for group 3 pulmonary hypertension. And that treatment is inhaled treprostinil. 22% of the patients enrolled in this trial had connective tissue disease, so a significant number had connective tissue disease. And with the inhaled prostacyclin, again, in group 3 pulmonary hypertension, there was improvement in 6-minute walk distance. There was improvement in end-terminal proBNP. There was an improvement in clinical worsening, namely less clinical worsening. That's, again, in group 3 pulmonary hypertension. So if you have connective tissue disease and you have pulmonary hypertension, it can oftentimes be difficult to distinguish between, do you have group 1 or do you have group 3? And now, at least, an argument can be made. Inhaled treprostinil is approved for group 1 as well as now approved for group 3. So the question that arises, at least, is that if you have someone with pulmonary hypertension, they have a mixture of group 1 and group 3, for example, as commonly happens in connective tissue diseases, should they be started on inhaled treprostinil? And we're all trying to figure out the answer to that. There are new treatments becoming available. Sotatercept recently published its phase 2 clinical trial showing a decrease in pulmonary vascular resistance, improved end-terminal proBNP, and interestingly enough, improved 6-minute walk distance as well. Now, we'll need to see if that gets replicated in the larger phase 3 trial, which also will include more clinical outcomes. As I often say, no one ever comes to me and says, my God, Dr. Ryan, I woke up this morning and my PVR was 7. Can you help me out? They come in and they say, my God, Dr. Ryan, I'm short of breath. I got leg swelling. Can you help me out? Other drugs that are being developed, seralutinib or GB002 is an inhaled agent which inhibits platelet-derived growth factor, which has been implicated in the development of pulmonary arterial hypertension. It's been shown to be beneficial in animal models and is now in the phase 2 trials. So, in summary, when it comes to treating pulmonary arterial hypertension, and in particular when it comes to treating connective tissue disease-associated pulmonary arterial hypertension, there's a lot of things that you gotta consider. You got to consider their functional class. You got to consider their comorbidities. If they're functional class, that determines what you're starting with. If you're starting with dual combination therapy, or if you're starting with parenteral prostacyclins. And then you got to follow them along closely and determine when you need to up-escalate therapy. And then finally, of course, as I said, there is this concern or this question about where does inhaled treatment fall in here, in particular for people who have a combined group 1 and group 3 pulmonary arterial hypertension. So thank you very much. I know that was quite the whirlwind through the treatment of pulmonary arterial hypertension. Thank you for sticking with me, and as it pertains to connective tissue disease. And I would love you to join me for Chapter 4, which will be discussing the multidisciplinary management of connective tissue disease-associated pulmonary hypertension. Thank you for your time. Hello, I'm John Ryan, cardiologist and director of pulmonary hypertension at University of Utah. It gives me great pleasure to talk about something that is very near and dear to my heart, which is the multidisciplinary management of connective tissue disease-associated pulmonary arterial hypertension. Within pulmonary arterial hypertension, there are roles from different clinicians, and there's actually a large role that the patient plays. So we want to touch on some of our own experiences in this multidisciplinary management of patients with connective tissue disease-associated pulmonary arterial hypertension. So no one ever presents to me, for example, without an echocardiogram. Anyone who comes to me as a cardiologist and anyone who runs a pulmonary hypertension center, be it cardiologist or pulmonologist or both, invariably has had an echo beforehand and invariably has been informed you have pulmonary hypertension. And then oftentimes it's up to us to figure out what the cause of that pulmonary hypertension is. In that setting, the most important aspect and most important kind of person who plays a role here is really the primary care provider. The primary care team are the people who are picking up pulmonary hypertension first because they're the ones getting the echoes. Now, it can be challenging to decide to get an echo because the symptoms are so vague. Patients are tired. Patients are able to do less exercise. But oftentimes it's important to develop, or in fact always it's important to develop good collaborations with the primary care team so that they can know when to look for pulmonary hypertension and then know how to contact you once they find pulmonary hypertension. The other big referral source is actually rheumatologists. Unsurprisingly, as we've mentioned, connective tissue disease-associated pulmonary arterial hypertension is so prevalent and so clinically significant that the rheumatologists really are on top of this all the time and really need to kind of have their eyes wide open for this disease state and then refer them on to us. There's nothing wrong with referring a patient on too early. Now, oftentimes people look at me confused when they find out I'm a cardiologist and I deal with pulmonary hypertension, and some people think I'm a cardiologist and a pulmonologist, and that's not the case. We've looked at this in our own work, and within the United States, 60% of patients with pulmonary hypertension are cared for by pulmonologists, lung doctors. 30% are cared for by cardiologists, and then a 10% is some sort of mixture, or maybe some surgeons in there, maybe even some primary care pediatricians as well. So it is not uncommon to have one or both of these of cardiologists and pulmonologists taking care of you. Within our team, we think it is at University of Utah, we do have a combined team of cardiologists and pulmonologists, and we do think it's important and useful to have both of those disciplines represented when caring for people with pulmonary hypertension. The reason in particular is because actually so much of pulmonary hypertension is due to heart disease or is due to lung disease. It's only that small 10% that's due to pulmonary arterial hypertension. As I like to say, any old Yahoo can take care of that 10%. It's the other 90%. That's what's complicated. You have diastolic heart failure, very hard to treat. You have chronic hypoxic lung disease, very hard to treat. But when you get referred to a pulmonary hypertension center, or when you refer your patients to a pulmonary hypertension center, what you want most particularly is you want a diagnosis. Are they group 1, 2, 3, 4, or 5? And that's where having a combined clinic where my colleague, Dr. Hatton, Dr. Beck, they'll present, they're both pulmonologists, they'll present cases to us and we'll look at it and say, oh, there's a little bit of heart disease in here as well, or there's no heart disease and it's all lung. Similarly, I'll have a case, say, for example, of someone with significant obesity and figuring out if it's just due to heart disease or if they also have obesity hyperventilation syndrome. So that's where this multidisciplinary team comes in. Then, as I like to say, the best medicine I have are our advanced practice clinicians, our PAs and NPs. They're our best medicines that we have because they're on the phones, they're seeing patients in the front lines, they're the ones who are following up the testing, following up the response to treatment, and they tell you what's actually going on. I will come in, hail fellow, well met, shake your hands, say how good everything looks and then leave. They're the ones who are left having the conversations with the patients about financial stress, mental health, side effects of medicines. So they really play such an integral role, and there needs to be really open and often communication between the MDs and the advanced practice clinicians. And then the nurses. There are nurses in expert centers such as ours, take a lot of phone calls, give a lot of results, raise a lot of red flags when appropriate. And then there are actually, for people who are started on pulmonary arterial hypertension therapies, there are home visits which are done by nurses. And they need to have our phone numbers too. They need to communicate with us, communicate with the patient. There needs to be open communication. So all of these, hopefully I've been able to get across the importance of open communication between primary care providers and the pulmonary hypertension team, rheumatologists and the pulmonary hypertension team. Even within the pulmonary hypertension team, there needs to be open communication between the cardiologists, the pulmonologists, the advanced practice clinicians, the nurses. And then there needs to be open communication with the people who are in the homes, the nurses who are visiting the homes. And then central to all of this, integral to all of this, is the patient themselves and them taking on a leading role in terms of their own management, advocating for themselves, educating themselves, and accessing and determining ways, working with the teams as to how to readily access their healthcare, as well as stay educated in their disease process. As I said, the multidisciplinary team is key for the diagnosis, helps iron out these group 1s, group 2, group 3s, group 4s. You'd be surprised at things that you miss. The risk assessment then is also useful, again, from different eyes, because if you have seen this before, the last person I saw with lupus, with this phenotype, didn't respond very well, or a conversation I had this morning with one of our physician assistants was a HIV-associated pulmonary arterial hypertension. Seen this before, this is the best medicine that you should use, let's see how that goes. So that risk assessment is useful, or someone with liver disease and say, whoa, if we don't get this person treated and if we don't get them transplanted, they're not going to do well. So very useful to have those discussions for risk assessment, as well as I said, for determining the first line of treatment. Is it combination therapy, or is it actually a scenario where a single agent is beneficial? Then nobody can do the monitoring all by themselves. You need a team to do the monitoring. And you also actually need the patient to do the monitoring too. So that's where, again, the role of the patient comes up, is that there's nothing more. My nightmare is when a patient comes in and says, listen, I haven't been doing well for 3 weeks or for 6 weeks, and they turn up to clinic and they look like they're about a step away from dying. You're like, oh my goodness, should have told me this 5 weeks ago, or why didn't you tell me 5 weeks ago? So there really is an important for the physician team and the medical team to more appropriately to do ongoing monitoring, but also the patient themselves, and then modify the treatment based on best practices and previous experiences. So I cannot overemphasize the role that multidisciplinary teams have. You need a different set of eyes, you need different perspectives, you need different skill sets. And that's what each of these teams bring, or each of these members of the team bring. They bring different skills. Complement that together, develop a respectful and open communication work environment, and then you're giving the patient the best chance that they can have to do as well as they can with a tough disease. Thank you for your time. This has been an enormous pleasure for me. I would ask you to complete the post-test and evaluation of this course in order for you to get your CME credit, and hopefully you enjoyed this series. Hopefully I was able to keep you or give you some extra teaching points while also keeping you engaged in this virtual world. If I gave you no teaching points and I didn't engage you, we'd like to hear about that too. So thank you for your time and best of luck.
This has been CME on ReachMD. This activity was provided by the Academy for Continued Healthcare Learning and supported by an educational grant from Actelion Pharmaceuticals US Incorporated, a Janssen pharmaceutical company of Johnson & Johnson. To receive your free CME credit or to download this program, go to reachmd.com/CME. Thank you for listening.